Welcome to the second session of this webinar series on vigilance of COVID-19 vaccines hosted by the International Society of Pharmacovigilance, the ISoP. This webinar series has been organized by the ISoP Latin American chapter in collaboration with the ISoP Israel chapter and the ISoP Special Interest Group of Vaccines. My colleagues and co-chairs are Rebecca Chandler from the Uppsala Monitoring Center and the Special Interest Group of Vaccines from the ISoP, and Irene Fermon from the Israel chapter. My name is Raquel Herrera Comoglio from the Latin American chapter and from the National University of Cordoba, Argentina. Today, we will have the outstanding contribution of Professor Jean-Michel Dogné, who will speak about the characteristics of authorized vaccines and their identified and potential risks. The experts invited for the discussion are Priya Bari from the European Medicines Agency and Professor Saad Shakir from the Drug Safety Research Unit, United Kingdom. Professor Jean-Michel Dogné is a pharmacist and a PhD in pharmaceutical sciences from the University of Liège, Belgium, and he was appointed professor of the University of Namur, Belgium in 2005. He is also the head of the pharmacy department. His teaching activities cover a wide range of topics: drug development, medicinal chemistry, human biochemistry, drug safety, and pharmacovigilance. He's the author and co-author of more than 250 papers published in peer-reviewed journals. He also developed a strong and recognized expertise in pharmaceutical regulatory affairs, and more particularly drug safety and pharmacovigilance. He's the past Belgian delegate at the Pharmacovigilance Working Party of the EMA and Belgian effective member of the Pharmacovigilance Risk Assessment Committee since July 2012. His specific areas of expertise in the field of pharmacovigilance cover a safety of medicines for selected systems organ classes, hematological and cardiovascular adverse drug reactions, medicines affecting the Q2 interval, vaccine safety, risk management plans, risk minimization measures, signal detection and signal management, quality in pharmacovigilance, pharmacogenomics, and pharmacogenetics of medicines. Professor Dogné, thank you very much for being here today. Please, the room is yours.
Thank you very much. I will switch off my camera to increase the possibility that you can hear me as well as possible. May I ask everybody also to switch off their mic so that it's easier to avoid background noise. Okay, so I have been asked to discuss with you about the characteristic of authorized COVID-19 vaccines and the identified potential risk. Of course, authorized is a bit difficult to me because worldwide there are many vaccines now that have been authorized and for which I do not have as much as information as I would like when it compares to my area of expertise, which is at the EU level. So I will take, I would say, example from the EU level, but that can be accommodated for the identification of identified potential risk and how to deal with this risk for any vaccine, maybe worldwide, of course, depending on the decision at the national authorization regulatory bodies. So first, as a disclaimer, I'm a member of, as it was said, of the Federal Agency for Medicine and Health Product at the Belgium level and member of the PAC of the European Medicine Agency, but my presentation is a personal point of view and binds in the way the organization mentioned there. So I think that now you are well aware of the concept of the SARS-CoV-2, of the COVID-19 vaccine, which is a vaccine intended to provide acquired immunity against COVID-19. And indeed, vaccine will mimic the immune response by humans to SARS-CoV-2. the virus using the surface glycoprotein called spike to connect ACE2 receptors and enter the host cell. Acquired immunity will occur as a combination of the cell-mediated immunity and antibody production. So we will have both the antibody production, but also the cell immunity, and you will see that for some vaccine, it's quite important. So we have different platforms of vaccine that have been, of course, developed, and most of the platforms of the vaccine candidates in clinical trials are focusing on the coronavirus spike protein. And you see here that many vaccine developers use the virus itself in a weakened or inactivated form. And the inactivated virus have been now clearly developed, especially in China, where they use at least 2 vaccines that have these specific characteristics. Of course, in this slide, you see that there are many different platforms that have been used. And in the middle, you see, for instance, that many vaccine developers use also some viral vector vaccines, and for which the one that has been the most described up to now is adenovirus, which is genetically engineered so that it can produce also the coronavirus protein in the body. And it is mainly some vaccine that we will see, AstraZeneca vaccine, the Sputnik 5 vaccine, which use in fact 2 different adenovirus vaccines, and the Janssen vaccine. And we have also on this slide the possibility to use a protein subunit, and this is the case from Novavax, which is a US vaccine that use specifically engineered protein subunits and that are used with an adjuvant. And this is the concern that we have with this vaccine. Usually they use an adjuvant. And finally, of course, the one that we are discussing a lot is the nucleic acid vaccine, especially the RNA vaccines. And 2 vaccines have been authorized, at least at the EU level, but also in many member states, in many countries, sorry. That's the Pfizer vaccine and the Moderna vaccine. And both vaccines work via this RNA that is in the vaccine, which carries out the instruction to make the SARS-CoV-2 spike protein. But the delivery of the vaccine, the delivery of the mRNA is achieved by a formulation of the mRNA into lipid nanoparticles, which protect the RNA strands and help the absorption into the cells. And once the vaccine is injected, the mRNA is taken by the macrophages, for instance, near the injection site and instructs those cells to make the spike protein. So it means that enzyme will, in the body, will degrade the mRNA, and so no virus, in fact, is involved. There is no adjuvant, and most importantly, you see that the genetic material does not enter the nucleus of the cells. As the 2nd of February, we have 63 vaccines that were in clinical development and 177 in preclinical development, according to the WHO. We have at least 9 different technologies, platforms that are mentioned here, and you see that the one that is more in development is the protein subunit, and you see that the RNA that are most used worldwide is not the one that is mostly developed, mainly because the technology is not such easy to handle, and this is also the reason why in the past there was no mRNA vaccine developed, I think, and led to the license, because mainly of technical concern rather than on the principles. Most of these vaccines are 2 doses regimens with an intramuscular injection. We have some development for also sub-oral development, but only a few of these vaccines. The 2 doses are in between 3 and 4 weeks, and we have some vaccine with 1 dose, Janssen being an adenovirus, which is proposed in 1 dose. This study identified between January 2010 and June 2020 the characteristic of the FDA approved 21 vaccines. Most novel vaccines approved by the FDA required about 8 years of clinical development and were based on evidence from a median of 7 clinical trials, including at least 2 pivotal efficacy trials that were randomized, masked, and used as comparator group. These pivotal efficacy trials enrolled a median of 5,000 patients who were followed up for serious adverse events for usually at least 6 months. And what we know is that we have the total patient in intervention group that is around 3,500 individuals. So it's quite important to keep that in mind when we will discuss for the vaccine the potential and identify risks of the COVID-19 vaccine. So at the level of different regulatory bodies, including the EMEA, at least at the level of the EU, there is a portfolio on the vaccine on the table. But what is important is that there was some discussion on how to handle the question of safety. And Priya will mention the difficulty that we have with the communication about the vaccine, which is generally associated not on the efficacy, but on the problem with the clinical safety. And you see that most adverse reactions to vaccine occur within 4 to 6 weeks from vaccination. And so in principle, at the EU level, a conditional marketing authorization of the COVID-19 could be based on the review of at least 6 weeks post-vaccination safety data. And you may know that at the level of the FDA, it was recommended that it was 2 months of the median of the participant after the second dose, for which we needed to have the information to have the marketing authorization. So it differs depending on the countries. And for the post-approval follow-up for safety and efficacy at this stage, it was usually requested that at least 1 year after completion of vaccination was requested. And we have difference in between some vaccines. For instance, the mRNA vaccine, it's usually 2 years. And for some vaccines, such as AstraZeneca, on the top of my head, it's 1 year follow-up. So as I have said, I did here take a series of vaccines. I did not take all the vaccines that we have been authorized in some countries, but the majority of one are authorized in the majority of the countries worldwide. So you have the Comirnaty, the Moderna, AstraZeneca, Janssen, CureVac, which is under development, and Novavax. And you see that at the EU level, at the minimum, they were authorized, the 3 first ones were authorized at the end of December and beginning of January for Moderna, and at the end of January for the AstraZeneca, with differences in terms of efficacy. And we need indeed to have also, regarding the safety, lesson learned from a novel vaccine introduction during a pandemic. And the only one that we had in the past was the 2009 H1N1 influenza pandemic that demonstrated that few countries had a pandemic preparedness plan, especially for regarding the safety. And on top of that, we know and we knew that there was the problem of vaccine-associated enhanced disease that needed to be taken into consideration. And as I have said, and Priya will mention about that, what is important to be prepared regarding the safety is that rumors of adverse events may lead to fears into vaccination and may compromise any vaccination campaign. So when it comes to the data of the safety, usually we take non-clinical, clinical data, and we put that in the risk management plan to identify potential and identify risk and missing information. And what is quite important in this case, you see on this slide that you indeed see that with around 15,000 patients, and you see that for the phase 3 study with Comirnaty, we had more than 20,000 patients, 20,000 subjects that were vaccinated. With the Moderna, 15,000 subjects. With the AstraZeneca, 12,000 subjects. So it means that we had, for efficacy, this number that were needed to have enough power to identify enough of events to make good estimate about the efficacy. But interestingly, what it helps us is that each case, each individuals may be used for safety reasons. And it has a clear impact on the chance to identify rare site events, 0.01%. You see that if you have 15,000 subjects that are treated, you have the chance of missing this kind of event, which is quite low, less than 25%. While, as I have mentioned, when we have with the different vaccines that have been authorized the past 10 years at the level of the FDA, it was around 3,000, and you missed these, or you have high risk to miss these rare events. So what is interesting with these studies is that when it comes to potential or identified risk, we expected to have more identified risk in these studies, and this was a consequence of highly porous studies to have the possibility to have good estimate about the efficacy. So again, if you take the more common adverse event associated with the mRNA vaccine, and more specifically in this case with the Comirnaty, the most common are associated with the reactogenicity, which were expected, headache, for instance, and injection site pain, but also fatigue, pyrexia, and which was with a higher frequency after the second dose. But the less frequency was seen with lymphadenopathy, for instance, and they were listed as identified risk. And you see, and this is quite important because it may be some difference in terms of transparency, I would say, in the different regions of the world, that at the EU level, we identify acute peripheral facial paralysis or Bell's palsy as an event that should be at least mentioned in the summary of the product information, since we had 4 cases identified in the vaccine arm when compared to 0 cases in the placebo arm. When it comes to the anaphylaxis, you see that depending, of course, on the country, we had few, even no cases in clinical trials, but post-marketing, since the vaccine was already introduced in some countries, such, for instance, in the UK, anaphylaxis was also identified at the level of the EU that market the vaccine later as a not known in terms of frequency or risks. And I would say the same is true for the Moderna vaccine. We had the same kind of adverse event identified in the clinical trials. You see that we also identified lymphadenopathy, and you see that we also identified some cases of acute peripheral facial paralysis with 3 versus 1. So again, we had I would say, disproportion of acute peripheral facial paralysis. And what was interesting is that the background incidence rate is around 1 out of 10,000 a year. And so we believe that it may be a signal not only of disproportion, but in the terms of number of cases observed when compared to the number of cases expected. And for the AstraZeneca vaccine, we took into consideration the 4 clinical studies. And for the efficacy, we took into consideration only 2 efficacy studies, but we took the 4 all clinical studies to identify also the risks in these clinical trials. And again, we are in line with what was expected. Also, the platform is different when it comes to the mRNA vaccine, except you see that we did not identify acute peripheral facial paralysis, but I will come on the potential risk that may be a bit different with this one when compared to other ones. And so this is how we work to also discuss about identify and potential risk. And the difficulty that we have is that we would face with applicants that would come with some specific risk management plan, some specific potential risk, and with some specific identified risk or missing information that would not be, I would say, adequately harmonized. And so what we propose at the EMEA level was to have a published core risk management plan. And what it helps is that being published, of course, the different applicant can use it as a template to propose a risk management plan. Who say risk management plan says identify and potential risk. But what we clearly focus on is the way that we wanted to have a potential risk that was driven by evidence-based. And it's quite important that needs to be driven by evidence-based and not having a full list of potential risks. For instance, the adverse event of special interest that could be mentioned in the risk management plan, but the one that would be evidence-based, taking into consideration, of course, some specific characteristics of the different platforms, for instance, the presence of an adjuvant, the vaccine construct, or the degradation of the active substance. So, for instance, what will become the mRNA in the body. For the identified risks, we clearly mentioned in this core risk management plan that it was acceptable, even from a communication point of view, and I think also that Priya will mention that it may be acceptable that no important identification risk was included in the RMP if it was not identified and studied also in post-authorization safety study. And for the potential risk, the aim is to focus on evidence-based coming from non-clinical or preclinical in this case, and clinical data. And we propose also a list of missing information, because missing information may be also a possibility to also focus on what will become the risk in terms of probability of an event to appear in this population, either because they were not studied in clinical trials. This is the case for pregnant women or autoimmune disease or immunocompromised patients that were not studied in clinical trials, while, for instance, frail patients were studied in clinical trial or elderly were studied in clinical trial, but the information may be a bit lacking. And you have seen that with the AstraZeneca, the EU has clearly mentioned that the data about efficacy and safety about 55 is maybe more limited than in individuals lower than 55. The safety of children, of course, will depend on the age group enrolled in the clinical trials, and we have difference in between Pfizer and Moderna and AstraZeneca. And so here is a table where I try to summarize what we can discuss in terms of what I was asked to discuss with you, the potential, the identified risk, and the missing information. And I put this table to show you what is in common in between the vaccine and where we might have some differences. First, as I have mentioned, anaphylaxis was identified at the time the European Medicine Agency assessed the data, because we had already some post-marketing evidence coming from both vaccines that were already marketed at the UK level, but also at the US level and at the Canada level, and also, of course, and in other member states. And so why anaphylaxis? Because we know that anaphylaxis may be associated to the vaccination. Also, we know that it's a very rare event. In this case, you see that the rate of anaphylaxis was 1.31 per million vaccinees. So we know that we will not identify this in clinical trial. We know that we can identify this quite rapidly, I would say, because it's a type A adverse drug reaction that may happen quite rapidly after the vaccination. And we also know that it can be associated with the composition of the vaccine. And in this case, we knew that we had, with this lipid nanoformulation, some specificity with some specific new, I would say, lipids that include for the two different vaccine polyethylene glycan, but polyethylene glycans are linked or are chemically associated in some specific lipids that were not used before in different vaccines. So it was something that could have been anticipated, and that what also was traduced in the real life. And indeed, in the real life, the CDC published on January 6th the data about the cases observed with the Pfizer vaccine, with an incidence of cases of 11 cases per million doses. And so it means that when you compare to all the vaccine in this case, for which you expect to have one every million vaccine, it's, I would say, an increased risk when it comes to 11 per million doses. And what was interesting is that the majority of the cases, 71% in this case, appear before 15 minutes, but both in previously in individual without or with previous history of allergic reaction. And you see what the age, the median age was around 40 years of age, but you see that the majority was 90% was the women was female. And the same was also published more recently with the Moderna vaccine, with a frequency, in this case, an incident that it's a bit lower, 2.5 per million doses when compared to 11 per million doses with the Pfizer vaccine. So the absolute number of cases is lower, but the patient exposure with the vaccine is also lower. But you see again that the majority, if not all, appear before 15 minutes. And again, 100% is with women, and the median age is around 47. So it can also allow to specify what kind of population we need to follow for at least 15 minutes, having maybe some specificity with females and without an age group that is with high age. And so this is why anaphylaxis was clearly mentioned. And you see that for the Oxford AstraZeneca vaccine, it was considered not as a identified risk, but as a potential risk. Why? Because the patient exposure, which was a bit limited at the time of our analysis, was lower than in real life with Pfizer and Moderna. And it is a different vaccine in terms of composition. This is a vaccine that is on the platform of an adenovirus, which does not contain pegylated lipids, but it contains polysorbate 80, which allow it to have this kind of cross anaphylactic reaction. And indeed, coming from the AstraZeneca, there was no so serious events of anaphylaxis in the clinical trial, which was expected because I have said that even if we have the background rate of anaphylaxis with any vaccines, the power of this study did not allow to identify such a low risks. So what does it mean is that for the 3 vaccines, irrespective of the number of cases in clinical trials and post-authorization, you will remember that the 15 minutes was really a cutoff timing for following the people to reduce the risk of not developing an anaphylaxis, but to reduce the risk to let people go and not be treated adequately. And so we propose to have appropriate medical treatment and supervision that should be followed for at least 15 minutes. And I can tell you that in many countries, we have many people that develop anaphylaxis, but using this recommendation, we have only few that are hospitalized because they are treated quite rapidly with the material that is available, especially adrenaline, for instance. And of course, the one that would develop an anaphylactic reaction after the first dose should not receive the second dose of the same vaccine at least. And what is important in terms of communication is that to remind that for the people that were a bit concerned about this risk of anaphylaxis, that this risk remained very low, even with the Pfizer vaccine or the Moderna vaccine, when compared to some risk associated with other medicine. And I took here the example of penicillin, of sulfonamide antibiotic, which is a higher risk, and even with OTC medicines such as NSAID. But you see also that for this one, what is also there is that we knew that we have a female sex, I would say, driven increased risk of this kind of anaphylactic reaction. And this is the same, therefore, for the anaphylaxis. And we also did a research in the ultravigilance database, and we see also that we have this increased risk in women. And quite recently were published at the level of the EMEA the monthly safety report with the 2 vaccines, Comirnaty and the Moderna vaccine. Moderna was published also last week, and at the end of January the Comirnaty vaccine. And so we of course fully focus on this allergic reaction. And interestingly, as I have said, in the ultravigilance, as with the CDC report, we were in line with the risk minimization proposed in the SMPC, the follow-up for at least 15 minutes of the population, and the majority of the events were in line with what was expected. And so this is a potential or identified risk depending on the vaccine for which we believe that the risk minimization are adequate. As I have said, there are some differences in between these vaccine, and if you take the AstraZeneca vaccine, you see that we have put nervous system disorder, including immune-mediated neurological condition, and you know that during the clinical development, some cases, or one case at least, of transverse myelitis led to a halting of the clinical trial program in different countries and a bit longer in the US. And so we put it as a potential risk. Also, what we get from the clinical development is that we know that the risk associated with the vaccine and acute demyelinating event is very low, if not, I would say, existing at all, that there is up to now no real causal relationship, and that in the AstraZeneca vaccine, overall, when we take clinically incidence of neurological event, there was no scientific significant imbalance in this risk in the 2 groups, but we put it as a potential risk, therefore, and not as a identified risks. And I put last but not least the one that with really theoretical, for which we have no clue if it can happen, and which is not evidence-based, but we felt that for different reasons, especially for communication reasons, it would be needed to be put as an important potential risk as well. It is the vaccine-associated enhanced disease, including vaccine-associated enhanced respiratory disease. And you see that this is the same for the 3. Also that for the 3, this is a theoretical concern that was observed for some of the vaccine in the past. And you know the example of formalin inactivated whole virus vaccine. And we had experimental model of the SARS-CoV-1 and MERS-CoV infection that may be possible in certain conditions. And in fact, we have 2 different syndromes that could be assessed or that could be discussed as a vaccine-enhanced disease. And now we have the Brighton definition that has been published of what we call a vaccine-enhanced associated enhanced respiratory disease, but we can have an antibody-dependent enhancement that is associated with a complex that will bind to the FCR bearing cells and that may trigger viral entry. But we have also the vaccine associated enhanced respiratory disease, which is associated with, from an immunological point of view, a more Th2 response from an immunological point of view. And so from a non-clinical point of view, we ask, of course, the company to assess what was the main driver in terms of immunological reaction of the vaccine. And usually for the mRNA vaccine, at least this is a Th1 trigger response and not the Th2 trigger response. But again, this is not a validated surrogate marker. This is just an information. But today we do not have this kind of cases. But we need to follow these cases. And so you have seen that I have said that we feel that what we call the potential and identified risk should be at least evidence-based, maybe at the exception of the vaccine-enhanced disease, but we have, and we know that we have a full list of adverse events of special interest, and we propose not to use it in the potential and identified risk, but these need to be followed in the different pharmacological activities, routine and additional pharmacovigilance activities. And you know that the lists have been published and lists have been updated. And you know that the CRMP has contracted with the Brighton collaboration through the Task Force for Global Health to harmonize the safety assessment of CRMP-funded vaccine via the Safety Platform for Emergency Vaccine, the SPEAK. And we have at EU level a project also, which is called the Access Project, that also focused on this list when it was also agreed at the level of different bodies at worldwide level, at the GRCVS, but also at the EU level, to use an updated list, which would be updated based on different new data, of course, to be used as an adverse event of special interest that could be followed when we do a specific signal detection of when we do also a post-authorization safety study. So this list is not the one that is the most complete, but I think the way it is presented is quite interesting, since it takes into account different table with the adverse event of special interest relevant to the vaccination in general. And you see that we have, as usually, GBS and anaphylaxis, for instance, but we have also the table 2 is the adverse event of special interest relevant to some specific vaccine platforms. And for instance, of course, we have myocarditis with MVA platform. And finally, the most, I would say, challenging one is the one for which we have events that may be associated with the symptoms of the disease. And the first one, of course, being the enhanced disease following immunization. And you see that the rationale is mainly the non-clinical studies and the fact that we have had in the past with the dengue vaccine and the RSV vaccine some cases that led to the change of the vaccination campaign. We have also the multiple system inflammatory syndrome in children, which is a disease that has been, I would say, now clearly described associated to the virus and the disease itself. And we have again a series of diseases associated to the disease, but that could be also associated to the vaccine and that need to be tackled as well. And so all of these need to be followed up, even if they are not potential or identified risk, but as part of the signal detection, and for instance, also as part of the post-authorization safety study. And you know that what is quite important to do so, to have good estimate about the patient exposure, is to have a good traceability system as well. That was also recommended for all vaccines, to allow to have the number of batch, the number of doses, and the brand name of the product that could be recorded to allow for good signal detection. And this is a slide from the EMEA that says that not only at the level of the EMEA, but at the level of the company, and maybe for different countries that could do signal detection using these adverse events of special interest. Of course, having some data now from the access program allow to have the expected numbers, so the background incident rate, to allow to make observed versus expected analysis, with the concern of the observed analysis that needs to have good information of the real patient exposure, not the number of doses distributed, but the number of doses injected. And I put you with the example, for instance, of Bell's palsy. This is what we use to detect this increase of the risk of Bell's palsy, for instance, but we had also imbalance analysis and time to onset, which is quite important. So for the adverse event of special interest, This is something that need to be done, but with some difficulties, of course, to have real-time data. And you know that we have the second, I would say, main topic that was discussed coming mainly from Norway, but related mainly from press, or I would say communication in the press, that was also mentioned in the BMT, for instance, is of course some cases of death in frail elderly patients, depending on the vaccination rollout in the different countries. For instance, in Belgium, where I live, we started to vaccinate first people that were usually over 80 and 85, people that were in facility. So basically, we know in Belgium that every 5 days, at this period, we have around 400 deaths in Belgium every 5 days, irrespective of the vaccination. So as the vaccine will not prevent usually the deaths outside, hopefully, of the COVID-19, we know that we expect to have usually around 400 deaths every 5 days. And so we had what we expected is that some coincident cases were reflected in the media, and you know that it came also from the Norway that they had a follow-up of a series of cases. And but still, that the recommendation I think whole is that the question is still to be good, that the vaccination is a question of benefit risk in the population, and the question to vaccinate every elderly patient, especially frail patient, need to be a question of the benefit risk. And again, it was good to be put into context that also in Norway, around 40 deaths normally occur every week in Norway. So this observed versus expected analysis should have been done maybe and anticipated, even in terms of deaths, to avoid some this kind of discussion before going to the media. And this was also assessed at the level of the GRCVS, at the level of the WHO, that says that the current reports do not suggest any unexpected or untoward increased fatalities in frail elderly individuals. And so I will now finish, and sorry, this is in French, but I can traduce you quite rapidly. And now I would say this is the vaccine versus the variants of concerns. And what makes it quite difficult now is that it's becoming difficult to compare the efficacy of the vaccines in between them, depending on the countries where they've been studied, the timing where they've been studied, and to say that, for instance, a Russian vaccine that has been studied in Russia only may have, for instance, more than 90% of efficacy, and for the Janssen, for instance, vaccine, or for another vaccine that have 65 or 60% of efficacy studied in South Africa, may have a lower efficacy. In fact, it will depend on what is the prevalence of the variant now in the population where the vaccine was studied. And the concern with the variant is especially the variants of interest, which are affecting the spike protein, and more specifically the receptor binding domain. And I put in this table 3 variants of concerns. The first one, and I'm sorry to call it the UK variant, because now it makes no sense to call from a country, but to call it the lineage, the B117. We know that we have 9 mutations of interest, especially one in the region binding domain, the N101Y, which is an asparagine which is used to a tyrosine. And the main concern is maybe an increased risk of transmission without an increased risk maybe of the severity of the disease. And now we can detect it by a classical PCR. The main concern with the South Africa lineage, but again the B1351, is that we have in the protein S mutation at least 3 mutations, of which 2, especially the second one, that may be more difficult to handle with. First, because we do not detect it by classical PCR, but it needs good sequencing. And now, for instance, in Belgium, we can do 1,000 sequencing a week, and while we can do every day more than 100,000 PCR. So, of course, we underestimate this variant. And we have also in Brazil and Japan another variant, the P1 lineage, that has been identified, and with the same characteristic of the South Africa. And so what does it mean? And it comes here from the CDC, that the B117, it seems that we have for the different vaccine the same efficacy on this variant. And the same being true also for the, I would say, natural immunity when you have been infected in the past with a wild type virus. This seems to be not the case with the B1351 South Africa variant, for which you have maybe you will affect the neutralization with the polyclonal antibodies, and the polyclonal antibodies is the antibodies from the vaccine, and the monoclonal antibodies, which usually is the natural immunity when you have been infected with a wild type virus. So this has been demonstrated, and depending on the study, on the neutralizing antibody, but maybe less with some vaccine than the other one, but not on clinical evaluation, except for the AstraZeneca now, but still, again, mainly on mild and moderate cases. And the same is expected also from Brazil. And there we have the limitation of the herd immunity when we have been infected in a high prevalence, in a high proportion of the population. We see that in 75% of the population in some cities that where we have the population infected with the SARS-CoV-2, the wild type, that now we have a surge in cases, meaning that the antibodies produced against I would say the wild type virus are not good enough or are not at a level enough to neutralize this variant. And so, again, this weekend, we had some, I would say, even not preprint, but data from the Financial Times and some data already published that the Oxford AstraZeneca vaccine failed to prevent, again, mild to moderate COVID from the African strain. And it led, of course, to many questions. First, we do not have the data on the severe cases, and we know that AstraZeneca is a real good vaccine on the severe cases. In the clinical trial program, we did not have hospitalization in the AstraZeneca vaccine group, while we had a series already after 21 days after first dose when compared to the AstraZeneca group, so vaccine group. And in this case, since the age was quite lower, we do not have severe data on severe cases. So we do not know the efficacy on the severe cases, but still, and this was published on the 7th of February. South Africa suspended AstraZeneca vaccines based on this data, and this was published on the 8th of February in Nature, that now we need also to consider that the vaccine is not, I would say, whatever the vaccine, is not a vaccine that is set in stone in terms of both efficacy and duration of efficacy. And we had many questions already in the past, because it's a safety and an efficacy concern, and you have seen that in the missing information, we have the data on efficacy and safety, and we have seen that lack of efficacy is per se also a definition of a safety concerns. But we need indeed now to reinvest in the way that we will work with these variants. And this is a Gavi information that was published yesterday, that manufacturer must be prepared to adjust the SARS-CoV-2 virus, the SARS-CoV-2 vaccine. And AstraZeneca mentioned that they would expect for autumn, for fall, to have the possibility to have maybe an adapted vaccine. The other mRNA vaccine are working also on possibility for boosters. And we need also that to have trials that must be also designed adequately to assess the efficacy and the safety of these new vaccine on potentially new variants, and of course to enhance genomic surveillance. And it creates also a lot of concerns, as you know, that with the COVAX facility, a series of vaccines were also signed to be distributed worldwide. And of course, and you know that there are countries for which we have few data about more specifically this genomic surveillance, and we do not know if what we send in some countries will also act on the good variant in this country. So there is a lot of work to do now. And I will close now with this manual that was edited by the WHO, that makes 200 pages. So if you want to have access, it's really a good manual that for which the JCVS has all worked onto it. And I will conclude with this sentence. I'm sorry that you would say that it's not the beginning of the end, but maybe the end of the beginning. And so now we have some vaccines, we have some variants. We need to work with both, not only on the rollout, but also on the efficacy and the safety, of course, the potential risk, the identified risk, and the long-term efficacy and long-term safety. I thank you for your attention.
Thank you very much, Jean-Michel. You have several questions in the Q&A, which you can, if you access the Q&A, you can read those questions. However, I can,
yes.
However, I can read them. So, or up to you.
Please. We have seen some patients that have an anaphylactoid reaction several hours after the first or second administration of the vaccine. Have you seen this? And how long, I guess, this adverse reaction could remain? Yes, we have seen a series of cases. We have the Brighton definition that we should use to report these cases. And in the Brighton case definition, you have different level of definitions. So we have seen this kind of cases, many, in fact, of these cases. And at least at national level in Belgium, we have edited a guidance to also follow these cases, meaning that the ones that develop after the first dose, these kind of cases usually are mild. They are not severe. They do not deserve adrenaline injection. But if they want to have their second dose, what we propose for them is to be vaccinated in allergology center or to be followed up for at least 30 minutes. But yes, indeed, this is the case. And if you read the CDC report, you will see that they discuss about real anaphylactic reaction. And what I can mention to you is that to use the Brighton definition of the case, which would be the best one. And at the EU level, the EMEA level, we have proposed some specific, with the company, some specific questionnaire for these kind of cases for the anaphylaxis and anaphylactic reaction. So yes, we have these kind of cases. For patients who may experience an anaphylactic reaction and the second dose is not recommended, would it be recommended to try with another brand? That's a good question, and that's an excellent question. The problem, as I have said, is that if you take, again, the mRNA vaccine and you expect that the risk is associated with the PEG, then indeed, in other adenovirus, for instance, vaccine, you do not have PEG. And so it may be a possibility, but we know also that there might be some cross-reaction in between PEG and polysorbate 80, and polysorbate 80 is at least in two adenovirus vaccine, AstraZeneca and Janssen. So I think the best way is if you have a first anaphylactic reaction is not to get the second dose if you do not know the reason why you have the anaphylactic reaction, and there are some possibilities in some countries to make tests to identify if the anaphylactic reaction was associated to the PEG. And if it's not to the PEG, then indeed you can anticipate to use a second dose. But again, and maybe it will be helpful to have also the one dose vaccine for these people that are at risk of anaphylactic reaction, because at one dose you will not get another dose, and for the AstraZeneca or maybe the adenovirus vaccine, we expect to have less risk of anaphylactic reaction. When and where will this recording be available after the meeting? I don't know, so I let that to the organizer. What advice is there for a subject to have past history of Bell's palsy? Which vaccine should they have, or insufficient evidence to say? Yes, it is not a contraindication. We knew that in the RNA vaccine we have had, as I have said, some cases. For the Pfizer 4 versus 0, for the Moderna 3 versus 1, if you make just an observed versus expected analysis, you would see that you would have more cases than expected, because it's 1 out of 10,000 a year with as a background incidence rate. But now what we have from the spontaneous reporting, it does not seem that we have many cases reported. We have, of course, some cases. So it is not a recommendation to not vaccinate this population. What I can say is that with the adenovirus vaccine, we have fewer cases, at least in clinical trials, but some clinical trials were less powered. No contraindication, but if there is some possibility to choose a vaccine, I would focus on an adenovirus vaccine. But this is not evidence-based. It is just an expert statement, I would say. Do any of the vaccine have shown proof of preventing or reducing contagiousness? There was a preprint of AstraZeneca vaccine published less than 1 week ago that showed that it may reduce the PCR positive in the vaccine group in asymptomatic population, and so that you may expect if you have less virus with less, therefore, PCR in the asymptomatic population, that you will be less contagious. So we have some clue there with the AstraZeneca vaccine. I think that with the Moderna vaccine, there was some also clue of some early data in the clinical trial program that shows some interesting trend, and maybe that we will have, of course, maybe more information in the near future, but it does not seem that we have, as we call, a full immunity in this population, meaning that we have a killing immunity that would also kill the contagious with all the vaccine. And I can also tell you that the SARS-CoV-2 can be also transmitted only by the not only by oral gootlets, but also by just contact. So in any case, there might be still some contagiousness. But again, the important is to be also vaccinated for yourself, because it decreases the risk of the disease at individual level. What do you think about the risks and or benefit using 5 to 6 vaccine in one country, and also about the surveillance? The surveillance is really associated in that case with the traceability, and the aim is to have a good traceability system in place. This is what we request, at least at EU level, for every vaccine, that allow to have good traceability system in place with stickers, for instance, with possibility to have also 2D or 3D barcode, QRD barcode, so that they can be put in a good registry, and this registry will clearly indicate the type of vaccine, the dose, and the number of the batch. And I think this is the only possibility afterwards to go good signal detection, especially, as I have mentioned, for the adverse event of special interest, the observed versus expected analysis, and secondly, to have, hopefully at national level, good background incidence rate for the adverse event of special interest, especially stratified by age and by some comorbidities, but I know that it's quite difficult for all these adverse events of special interest. So I do not think that it's a concern. The most of the concerns today is that even if we have 5 to 6 vaccines, we cannot have up to now vaccine for everybody. So I think we are running up for the vaccines to come, and having some different vaccine may help also. And finally, we have good interest to have with the variant some interchangeability study. This is not recommended today, but it would be good maybe to have interchangeability study. If you have been vaccinated with an adenovirus, having a prime booster with a RNA vaccine should be studied as well, since it may lead to more specific polyclonal antibody, I would say, produced that may prevent more clinical cases of specific variants known, and maybe more to come. In case of AstraZeneca vaccine, if they are reporting any hypertensive reaction, which excipient could be the reasons? I did not check that in details, if there were hypertensive reaction. I know that there is not really, I have put the excipient that you have, there is not really some problem with what of the excipient. And I remind you that you inject intramuscularly in the shoulder only 0.35 milliliter. So it's really low. So even I do not see how an excipient could increase your hypertension. What it can be done is that you have local inflammatory reaction that may impact maybe I would say the vasosystem, maybe an hypertensive or hypotensive. We know that we have some hypotensive reaction that are well known, but I did not check that in detail. Okay, I think that the exposure to vaccine in breast milk and during pregnancy is still unknown. However, it's seen that pregnant women are encouraged to vaccinate. What is your opinion? We have some clear wording in the SMPC at EU level that says that no, the non-clinical data do not show an increase of harm in pregnant women. We do not have data on the lactation. First, on lactation, you know that even for the mRNA vaccine, if you would have mRNA in the milk, even in the gut of the baby, the mRNA will totally be destroyed. So I think there is no risk for the lactation. The WHO made also some statement at that EU level, at least in Belgium, we made some statement that we do not recommend systematic vaccination of pregnant women, but on a case by case, on a benefit risk assessment, it cannot be excluded. And I know that for instance, in the US, they vaccinate a lot of pregnant women. So it is not a contraindication. Even not, I know that in the UK at the beginning, there was a recommendation not to be vaccinated, and now they have changed with the more careful, I would say, benefit risk assessment, even in women of childbearing potential. So pregnant women, I have answered. We are accumulating evidence, and I have not mentioned that this is a missing information. All the marketing authorization do conduct study in pregnant women in registries, but also follow pregnant women adequately as part of their risk minimization plan and their risk management plan. So you can read in detail this risk management plan. They have been published associated with a full transparency policy at the level of the EMEA, so you can easily read what has been done, and the same being true for the pediatric investigation plan. The burning eyes and blurred vision with AstraZeneca can be attributed to the excipient. To be honest, I don't know. Again, I think it's more associated to a reaction. I did not put all the excipient of the AstraZeneca, but this is a quite safe vaccine also in terms of excipient. You do not have to expect many things from the excipient, no preservative, no adjuvant in the AstraZeneca. So I think it should not come from an excipient. I have some patients that remain with mild symptoms of the adverse reaction that do not allow them to continue with a normal life. There are no severe, but how long could this reaction persist? What we have seen in clinical trials that indeed in between 1 to 2% of the population, depending on the vaccine, you might have more severe adverse drug reactions. So not automatically serious, but more severe. And indeed, you have a severe fever. If you have cephally, then for 1, 2, or 3 days, it may be quite difficult for you to have a normal life. Just an example this morning, I was called by a nurse that explained me exactly the same thing for her. And usually it lasts for 2 to 3 days. And so that's true that it can lead to that. But for people that have had even mild or severe COVID-19 disease, I can tell you that you prefer to have these events associated to the vaccination than the events associated to the disease itself. So, but yes, I would say 1-2% of the population vaccinated, and depending on the vaccine, it can happen. Is it possible to switch to the brand of vaccine? I mean, if someone receives Moderna, this is not recommended. Of course, if you have shortage issues, if you have been vaccinated first with Moderna, then the second dose could be Pfizer if you do not have Moderna at all. But this is not recommended to switch from a brand to another brand at this stage. I think I have answered all the questions.
Yes.
So I think that Saad would like to say something.
All right. I mean, thank you very much. Thank you, Jean-Michel. That was a comprehensive tour de force, and it covered a lot. Just wanted to have a few comments. I mean, obviously, it was right to follow the concept of potential risk, identified risk, and missing information. And as you said, the potential risks could be anybody's in people's minds, but you rightly are focusing on the evidence base. Obviously, the potential identified and missing information has been more used for small molecules. When you're talking about a vaccine, which is given to millions of people, one has to approach it differently. And there are some parts of the focus by regulatory authorities has been on the potential and identified risk. The missing information has been somewhat missing. For example, we have missing information in the immunocompromised people. We still don't know the efficacy in these people from immunogenicity by way. Do they produce sufficient antibodies and the clinical outcomes? And this is an area which I think can be identified from the post-marketing usage, if that is done in a systematic way by way of registries, for example, and the same thing with the people who have immunogenetic diseases. That's one of the areas. The other point which the regulators and everybody has put a lot of emphasis on adverse events of special interest. This is a long list, and some of the definitions in it really belong to whole virus vaccines, whether they are inactivated or dead viruses. For example, the things which the regulators are very, very much focusing on, and we have been asked to include in our studies for these vaccines, is the activation of enhanced disease. This may apply for a whole virus, but when you are giving people mRNA vaccines to produce just the protein of the spike, the plausibility of them causing enhanced disease is just not there, while the two entities which you mentioned is the antibody development enhancements and the vaccine associated respiratory disease may apply here. So we really need to be selective in the application of the events of special interest, depending on the vaccine. The other point which I wanted to mention is that while we are focusing rightly on evidence-based potential risks, one of the things which we all get inquiries about, these RNA things are going to our cells. Will they affect our DNA? Will they make us different people? We all know that both, there was a question to you, both the messenger RNA engulfed in a lipid envelope, as well as the non-replicating adenoviruses, they just are there in the cells. One of them is in the cytoplasm soup, and the other one, both of them degrade very quickly and disappear from the body, and they are not attached to produce the spike antigen, nor in any other ways. They will just disappear. And that's a point which leading to some hesitancy. The other point which we need to make is all the regulatory authorities, the MHRA, EMEA, FDA, other agencies are producing very, very good information from the spontaneous reporting. We always say spontaneous reporting suffers from inaccuracy of the denominator and underreporting. These two problems are far less pronounced with the vaccines. We are very accurate to the day, to the denominator, and the reporting is very good. And we have to say, I don't know how many millions around the world, 12 millions in the UK, 2 or 3 millions in Israel, so many in America. We really now have a good population. We haven't looked at them in details, but these events which we're all concerned about, which you mentioned in the first few weeks, up to 2 months, we're really not seeing anything major so far from these. So the short-term safety of these vaccines is so far being reassuring. I mean, all the arguments about efficacy in these variants, would it protect from transmissions and so on, all the questions, or nearly most of the questions which are being raised about these vaccines, about their efficacy in general, efficacy in special situations. But from the safety point of view, so far so good. We really have quite a few millions of people who have received this since the beginning of December or earlier with no major efficacy concerns. So thank you very much for your presentation. My points are really to add small bits to the massive amount of information which you have given, but just really to emphasize a few points. So thank you very much, Jean-Michel.
Thank you, Thad. Thank you.
Yeah. Priya,
Priya, yes.
do you want to comment?
Yes, I would love to. Thank you so much. It was exciting to hear both Jean-Michel with all the wonderful overview and a lot of details and the reflections from Saad. And I would like to follow up on the topic Jean-Michel has already mentioned a few times about how to communicate actually on the safety and on what we know and what we don't know. And I would like to reflect a little bit on what we do in the EMA at the moment, because we in fact publish a lot of information. I think it will be interesting for everybody to know where to find it. But also, I would like to share some early learnings. We only started 4 weeks ago with publishing. The concept development for these publications started way back many months ago. And a lot of thinking has gone in, and I would like to share a few things which I hope can also help all those who are in communicating roles. And in fact, we are very much motivated to communicate so much on safety because it has been identified with lots of research as one of the drivers for people deciding if they will get vaccinated, yes or no. And when we decided originally for a lot of enhanced transparency from EMA side, like putting out the risk management plans, for example, we also knew that this on its own will not do the trick. You need to also be able to put out communication which more packages the information in a sort of narrative way, something which is contextualizing the safety data with the exposure, with the background risks, and also in relation to other medicines. And I have to be honest, this is all good principles, but in reality is much more difficult to do. We are still in the process of collecting exposure data, specifically in Europe. We also know that background data have been criticized in the media of relating to longer time spans, like background incidence relates maybe to incidents in a year. Then people say, if it just has been used for 1 month, is it justified to compare the background rate in that shorter time frame? I mean, these are the questions which come up in the media. So the contextualization, as good as it sounds in theory, is much more challenging in practice. And we are really applying the good principles, but we are learning as we go. And we also receive feedback from our stakeholders. And that's one of the key messages I also want to give whenever you do communicate. Try to get a small, fast, effective stakeholder network around you with patient and healthcare professional representatives who give you feedback on what you do. And that's what we have been doing. But again, the challenge is that the questions they have been raising are mainly in relation to immunocompromised persons, special patient groups where we don't yet have so much data. But the fact that we're constantly in dialogue, I think it increases the trust. And we also get a lot of questions from individuals, and our stakeholder department answers them one by one, because in particular, when you don't yet can answer all the data and all the questions in a data-driven way, the important thing is to maintain the trust and the care and show that you care about each person until we hopefully have more data soon to reassure the public. Now, I want to come back to this challenge around the methods. I think we are always very focusing on having our risk assessment and trying to match in words the outcome of the assessment, that it translates into a risk perception in most people, which sort of comes together in a nice way. What we often forget is that to explain the methods we use is equally important. And I'm drawing that from two examples. One is ways back from the HPV vaccine experience, where there has been a lot of, we did a full media monitoring at the time in 2015, And people were wondering how we go about underreporting, because as pharmacovigilance people, we always say there's underreporting, report more. And all of a sudden we say, these are the number of cases we have. And they say, well, what about all these underreporting cases? Recently, and also at the time, and comes back now in this incident, is to explain the essence of expected versus observed analysis. And I've just mentioned already the tricky bit about where these background data come from and to which timeframes they refer. But also, Jean-Michel made quite detailed example about the sad cases of death in older people, which occurred in Norway. And obviously, we did multiple things in the EU. We looked at observed expected data. We also looked at each case individually. And when we communicated, we focused much more on the individual case review. And I have to say that I'm glad we did, because some other organizations did not. They would put more emphasis on the background rates and the all-cause mortality. And they were criticized in some media for, you see, they don't look at the data. They don't look at any individual. They're just statisticians. So here it clearly shows we need to show all our methods, not only pick one. The perceptions also go very much how people perceive what we do. So we have to show who we are, how much we care. We have to show in very detail how we do, and then only we can package also what we know in a way that hopefully will convince those who are open to the science. So with these words, I wanted to share a little bit with you our early experience, and I hope it's inspiring. And maybe one more thing is that because we are data-driven as regulators, we cannot give all the best expert opinions on those patient populations where we currently don't have yet all the data. But then the learned societies, I've just seen this morning publication from a Society for Multiple Sclerosis. Then there is a gynecological society who has been advising on use in pregnant women. The learned societies at the moment, they pull together a lot of data and give best expert advice. And for the healthcare professionals, it will work together. They will hopefully look what we do, but they will need to rely on these best expert opinions also from the learned societies. I'll stop here. Thank you very much.
Thank you very much. Thank you very much to Professor Jean-Michel Dogné and the panelists. There is still room for some questions. This session should end at 12:30, but we have some minutes. I don't know who wants to make a comment. Okay. Ulrich?
Yeah. Hola, bonjour Jean-Michel, merci beaucoup. I have a question which is not directly related to the products, but to the methods in the ongoing clinical studies. As I understand, the whole population in these studies are followed up to 1 or 2 years. Is there a methodological problem that, let me say, in 6 months, the participants in these studies in the placebo group will go away from the study, or will ask, no, I have perhaps only a 50-50 chance to get vaccinated, and to get my risk to get a COVID-19 is greater. I leave the study, so that at the end of the 1 or 2 years, we don't have the full placebo and comparison group.
Yes, this is a problem that has been discussed in different regulatory bodies, of course, because we expect to have from different clinical trials ongoing some dropout based on ethical conditions that it's quite difficult up to know that you have in a study where you have a vaccine that has shown 95% efficacy and that you still need to be followed for up to 2 years. And depending where you live, to be at higher risks of having the disease, to expect to have this population continue blinding in this study. So what we have said is that globally, of course, the best would come from a continuation of the study being placebo control, but they have the possibility when they sign the informed consent to drop from the study. So we expect indeed to have a drop of the group in these studies. What I would say is that hopefully we have also the possibility, if we unblind, to still continue follow the vaccine, the people that receive the vaccine, at least for vaccine, I would say, effectiveness in this population. And there are some discussion in the new clinical trials that will start to make non-inferiority studies. Of course, but the difficulty there is that you need also to have the possibility to have the comparator, the vaccine available in these clinical trials. And there are some difficulties also to have from the company allowing to use their vaccine in comparator, in clinical trials, even in non-inferiority studies. And so, yes, this is challenging in the future. This has been clearly notified, not only for the ongoing studies, but for the coming studies. And I expect that we will need to focus more than ever on the database, on the pharmacovigilance for the safety and for efficacy, or more adapted way to assess the efficacy in long terms. And we have many effectiveness studies, and the company, when they have marketed, they have their marketing authorization, at least at EU level, they have some obligation also to do effectiveness studies outside clinical trials. And I can tell you that now with the variants, depending where you do the study, I would really more rely on effectiveness study in real life in the countries rather than in clinical trials, in fact.
Merci beaucoup.
This is sad. Can I say something about this? I
Yes.
mean, in the AstraZeneca protocol, every person who is invited to vaccinate now should, they don't know whether they are on the vaccine or the placebo, should inform the study managers 3 days before that, and they will have a blood test. Then they will get the vaccine and they will be censored from the study ULREC. And I agree with Jean-Michel. In the future study, we have to think about other methods, including Bayesian methods, including non-inferiority and so on, because we are having, I mean, in many countries, we are having a diminishing non-vaccinated comparators, and the non-vaccinated will be people who have issues, anti-vaxxers, or have health contraindications and so on. So we have to think about research methods. But I know at least for one study, you drop out within the rules. You're not violating any protocol when you're offered a vaccine, but they want to take a sample from you. Sorry to interrupt.
Thank you, Thad. Just to say, yes, Irene, go ahead. Irene, you're mute, your mic.
Thank you, Jean-Michel. It was really very, very interesting. I would like to come back to your answer about mixing two different brands. In fact, I think that in UK, they have started to mix two brands. And in fact, is this a possible strategy to fight against the new variants?
Yes, I think that this strategy, as I have also answered yesterday in the media, that this strategy should be scientifically driven rather than, I would say, an option. I think why scientifically driven is that I am convinced that if you do an heterologous prime boost, you have the possibility to produce different polymorphic polyclonal antibodies that may be more interesting as a cocktail to prevent more the disease by the different variants. This is, for instance, mainly the case for the UK variant, the British variant. What I don't know if it's the case for the South African or the Brazilian, because there I think we need to use the most efficient vaccines on these variants. And so that's the difficulty with the AstraZeneca. I would hope that we could have some data on the severe cases induced by the variants. But I think that maybe in the future, this is what we will need to do to get the best protection. Again, the difficulty now today is to compare efficacy of the vaccine when they've been studied at different time in different regions of the world. We have seen that with Janssen vaccine. You have in the US 77% of efficacy. You have in the South Africa less than around 60% of efficacy. With Novavax, we have seen also that we have 90% of efficacy in some member states and 60% if you go South Africa. So it's quite difficult now to study, but it means that the different level of antibody, and we do not have yet today a good surrogate marker of the efficacy of the vaccine. So what we call a correlate of protections. So we still do not know what to measure to see if the vaccine will be effective. And the studies that we do in laboratory, and we do that in our laboratory as well, the seroprotection when we use to test the antibody from your serum, if it works on the variant, is still a laboratory study. What is best is to have clinical data. And there, of course, we are lacking a good experience with the majority of the vaccines, and it depends on the proportion of the population that got the variant. So this is why I think this is really the beginning, not the beginning of the end, but the end of the beginning. And now we will have to work with different vaccines, with different variants, with different regions. And I'm convinced that maybe this interchangeability from a scientific point of view will be the best way out to keep on the different variants.
Thank you.
Thank you. Thank you very much. The time is over now. We have to finish. And I want to thank you very much, Professor Jean-Michel Dogné, for this excellent presentation. The presentation for all the participants will be has been recorded and will be uploaded in the ISoP YouTube channel and available for everybody. And now I want to present the next session, the third session. Professor Saad Shakir will speak about the observations and experience of the vaccination in the United Kingdom. So the next Thursday, not the Wednesday, but the Thursday, we will be waiting for the Professor Shakir conference. Yes. Yes, Irene? Okay, nothing. So bye-bye, everybody. This was excellent, and thank you